be speaking on their projects and their continuing work in this space from our 2023 group. The Climate and Health Equity Fellowship was founded in 2021. Our founding director is in the audience, Dr. Mark Mitchell. This year, we have undergone a transition. I'm Dr. Shanita Johnson. You may remember me as a 2021 fellow and now serving as the director of this fellowship. My co-moderator is the associate director for the Western cohort, Dr. Venice Curry. We are just coming from our orientation where we welcomed our 2024 cohort, which is the fourth cohort of fellows, representing fellows from Florida to Hawaii. 12 fellows, diverse in specialty, diverse in what they bring to the table. And that is what this fellowship is about, empowering doctors of color to represent their communities and to be leaders in the climate, health, and equity space. We also launched our Peach Fellow and Fellowship, the Policy, Experience, and Equity, Climate, and Health in partnership with NOAA. And we have several of our partners for our fellowship programs here with us. Thank you for your support. Our first fellow will be Dr. Esmeralda Morales. Dr. Morales joins us from California, where she is a clinical assistant professor in pediatrics at Stanford. She's a pediatric pulmonologist. Welcome, Dr. Morales.
Thank you, Shanita. Can y'all hear me? Yeah, all right. There we go. So this talk really started as a 3-minute presentation for graduation or our fellowship graduation. Actually, I had to miss graduation. My mom passed away. And so it kind of threw me for a loop for a little while, but I'm here and I'm really grateful to be presenting and to be have been part of the Chef Fellowship program and to now be an alumnus. So I'm going to talk about the first slide. The nice thing, and I told the Chef Fellows today that the nice thing about having some more time to talk about the work that I started with Chef was that I could talk about story and my story, because I learned through the Chef Fellowship the importance of story and how that can impact people and motivate people and change things for the better. So there are 2 pictures that you can see on these slides. So the first one over here, it's interesting, I'm wearing the same thing, so it's good, consistent, comfortable DC wear. So this is me with a group of incredible people, and this was as a part of participating in advocacy days with a group called Green Latinos. And Green Latinos has been in existence for 15 years. They had their sort of 15th year anniversary and did a fly-in in September. And there were 20 to 30 of us who went around to congressional offices. I was the only physician there. So it was exciting. And I was able to interact with people who were really working in environmental justice and in the community. And then to me, that was one of the most meaningful experiences, because as a physician, I don't usually get to see that, right? I see patients. I'm a clinician educator, so I am not, my FTE is not, 90% research. It is interacting with patients. And as a Latina, I see a lot of Latin patients, they're like they come to me, So this was incredible. I was able to interact and get to know people who worked, one person, Paulina right there, Paulina Lopez, works as an executive director of the Duwamish River Coalition. So really, really engaged in environmental justice in Washington. And then I met Wesley over here, which I guess my pointer doesn't work, but he works, here we go. He works for his own sort of organization that takes Latinos, like Latin families, and kind of exposes them to the outdoors. And then we had some other people with us within Green Latinos who have been really, really, really engaged in this process. And as a physician, again, not something that I'm always that I'm always engaged with, but that was meaningful. The second meaningful picture from there, over here is Dolores Huerta. And oh my gosh, hello. She is a saint to me, right? She is the queen of organizing, co-founder of the United Farm Workers. And the phrase that we get from her, si se puede, right? And the story again was within, si se puede, yeah. That, and some point she was organizing in Arizona, and the farm workers there were like, no, no, no se puede. We have all these barriers and stuff like that. And so there is no way we can get any of this accomplished. And she's like, no, si se puede. Like, you can. So this is, again, what I'm trying to build my project, or try to build my project around, was building physician advocates and uplifting voices. Because then for a lot of us, it's not second nature to go out and say, like, hey, we need to talk about climate change and how it's affecting our patients and our communities. So this is the rest of my background story here. So these are basically 3 women that have affected me quite a bit, people whose shoulders I stand on. Over here is a picture of my grandmother. It actually is a hand-colored photograph. So back in the day, they used to take pictures and then they used to hand color them. So my grandmother, Spanish-speaking, crossed over from Mexico during the Mexican Revolution, settled in Laredo, and they used to just go back and forth. It was kind of a freer border then. And she told my dad once, like, I wish I was a man, because if I was a man, I could actually get stuff done. I could do things. And she had all these values and aspirations and ideas on how to make things better. But she was a woman. She was a Latina. She was not English speaking. So she felt very much like, I can't get any done. No voice. In the middle is basically the only sort of picture that I have of my mom's mom, so my other grandmother, which is a gravesite in Oklahoma for Elisa Reyes Uriegas, who basically, she passed away at my age, which kind of scares me, but also very quiet. That's how she was described by my mom. I say, what was your mom like, Mom? Quiet is what she said. Oh, she was quiet. She had a lot of problems. She had serious depression, was hospitalized in the state mental hospital. Back in the day, 40s, 50s, in Texas, where they would do ECT, and not benign ECT, right? So a lot of hardships here. And then that's a picture of my mom when she was younger. She was probably maybe in her early 20s then, in the early 60s, real blonde hair and everything. Same thing. She was described as quiet. She had this frustration inside. She knew what was the right thing. She knew what she stood for. She did not have a voice. All of them never felt like they had voices. And one thing that I learned over and over again from Chef Fellowship is the importance of voice. Position that we have as physicians. It just blew my mind that people trusted us. Me? What? Trust me? Why? Oh, wait a second, I'm a physician. I'm a Latina physician. So I do represent California, I can tell you, 39% Latino population. 6% of the physicians in California are Latino. About 2.7 are Latina. So not a lot of us, but we have some influence. And so the problem that I was looking at was that Latinas are underrepresented in medicine and underrepresented in climate advocacy spaces. And our professional organization, which is called the National Hispanic Medical Association, is uniquely positioned to amplify climate, health, and equity advocacy in the Latina community. And really, a lot of this it's a big project. So my goal was to basically form a council on climate change and health to recruit physicians from our organization to basically help with these issues, to amplify voices, physicians that are already engaged in communities, because we're here, we have all this energy, we need to do something with it, and we actually all do have a voice collectively. And so the other thing is we were talking about how can we do this? And I met with one of the government affairs and policy representatives there, and he said, you know what, we do a lot of policy statements. So, when we identify an issue, laws that are being thought of, like a lot of the laws on extreme heat, and how do you have protections for that? We could actually have policy statements. And we were like, oh yeah, any kind of issue that comes up when it's, as they are relevant, we can put these statements out and issue them as a group, and then let them kind of funnel down to the members as well, to try to amplify the voice. So basically came up with a process for that. And I just want to go kind of backtrack a little bit, with climate change and Latina issues. This is not exhaustive whatsoever, but a lot of the things that we're talking about is extreme weather events, heat-related issues that y'all have heard a lot about that today. Latinos are overrepresented in a lot of the outdoor occupations, farm workers, construction workers, and everything. So these protections are important. California does have protections, but again, as we heard before, there may not be as much staff to kind of enforce those protections. Still, I think that's better than not having any. My brother, who lives in Texas, is a landscaper. There are no protections there. You think about flooding. In California, we also have a good amount of wildfires. And both of those can actually really impact housing. And my patients have been affected quite a bit. With the floods last year, I had patients whose homes were flooded. And after the floodwaters recede, there's mold everywhere, there's wet things, there's everything. So it's really uninhabitable for a while. But California is an expensive state to live, not just on the coast, but everywhere. It's an issue, it's hard, and it just filters down through everything. And then air pollution. I'm a pediatric pulmonologist, and one of my specialties is asthma. So this is near and dear to my heart. And just kind of as an aside here, one of my pediatric pulmonary friends who lives in the Inland Empire in California. Inland Empire is basically Southern California. Los Angeles is here. If you go inland and it starts to look a little bit more deserty, that's the Inland Empire. It's a big area. This is a picture from her plane. Do y'all know what those are? Y'all know this morning, know what those are? Warehouses. Yep. There's a big, big, big presence of Amazon warehouses there. And there's a lot of traffic that goes from the Inland Empire to the Port of Los Angeles and Long Beach. And if you look at a map of PM 2.5 diesel, so PM 2.5 concentration in diesel emissions, if you look, you can actually look, it's just all the center of California. And if you parallel that map to asthma, ED visits, very high, very high. Y'all know who lives in the Inland Empire? Black and brown people. So so this is an issue. So we also talk about access to clean water and climate migration. And so the key actions, as I said before, I met with the government and policy representative to kind of discuss, are there ways that we can just try to get our foot in the door and try to do some things? And so we, came up with the statement writing and submitted and documented the process. I participated with Green Latinos in this Hispanic Heritage Month advocacy days. And NHMA has actually partnered with Green Latinos a lot of times, and has kind of helped them, or also uplifted sort of one of the publications that they came out looking at Latinos and climate change and how we are affected. And then there's this big process. So part of this process was learning the organizational structure of this professional society and really going through all of the hoops and forming the relationships that really it's going to take time to, but I sent in an application for approval for formation of the specialty council and identified a co-chair and everything. So the next steps really are to co-chair the council, and then set up the initial meetings and build membership and, plan these webinars and advocacy toolkits, and then just really try to build this sort of entity where we can really, 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 really affect change. So it's still a process that's going on because forming relationships takes a long time. And it's also, there's challenges to every association and things that I have heard repeated in terms of funding for viability, those type of things, membership, and who's interested. Apparently, the physicians that are my age in NHMA are the least active and it's hard to recruit us. But the people that they are seeing and the people that are kind of having this hope for the future are our trainees. So our residents, our med students, our people that are even undergrads that are interested in doing medicine, what they've been seeing, the people where they're seeing sky-high membership numbers, those are the people. And then, so I talked this morning about this bird picture here, and part of it, Dr. Curry had reviewed my slides before, and I had a picture of this beautiful snowy egret kind of juxtaposed with another picture at some point of a scrub jay. And a snowy egret it's a coastal bird, and it's thought to symbolize sort of grace and simplicity and peacefulness. The other bird that I had on there is a California scrub jay, and I don't know if y'all know anything about California scrub jays, but they are obnoxious little birds. Just, it's sort of like what I was thinking about is really thinking about like voice and how voice is used. So there is voice that is used this way, graceful, simple, composed, right? And then there's scrub jay, right? And scrub jay a lot of times is what gets the looks, right? It may not have very much substance and everything. I have to say the three women that I showed you, my grandmothers, my mom, when I heard them described a lot, this is what they had, but they still weren't able to use their voice. I have a voice and I have opportunity. I can. They also a lot of times had a big scarcity of hope. That scarcity of hope that a lot of people feel when they feel climate anxiety, and when our chef orientees, they get bombarded with, I don't know how many hours of climate education all at once, right? The thing that makes you just want to hide under the covers and go like, oh my God, the world's gonna end. No, right? But there's hope, right? We have hope. And I think, it's interesting. I learned a phrase today. So this meaningful coping, that is really important. I think I might have asked you, Ed, after like a year ago, you probably don't remember. I'm like, all of this going on, how do you really, really, really think this is going to work? Is all of this voices and all of this, we're going to amplify stuff, and this is how it's going to, how it's going to work? What world does this come from? It doesn't come from my mother and grandmother's world, I can tell you that. But that's okay. It's sort of like, no, we have to do this. And this is a quote from Barack Obama, and I told everybody this morning, I miss him. So hope is not blind optimism. It's not ignoring the enormity of the tasks ahead or the roadblocks that stand in our path. It's not sitting on the sidelines or shirking from a fight. Hope is a thing inside us that insists, despite all evidence to the contrary, that something better awaits us if we have the courage to reach for it and to work for it and to fight for it. And I got y'all are fighters here. I have all these fighters on stage and in the audience. So sí se puede. And these are the people that give me hope besides everybody here. So I have my Latinas here. These are some trainees that I met at NHMA. Wonderful, wonderful doctors. There's one of our resident trainees, Daphne Galan, actually talking at a Latino Physician Day. This is my group from Green Latinos during our advocacy days. And then this is my family over here celebrating my parents' 50th anniversary. My mom's a little worse for the wear there, but like, these are my cousins. They're singing, they're uplifting their voices. They're uplifting their voices in celebration and hope. And that's what we got. And we've got our work cut out for us. So thank y'all.
Thank you. Thank you so much, Dr. Morales. Fantastic work, and we're excited for you to continue forward. Dr. Watkins, you've met already in the last panel that he so expertly moderated. He is an assistant commissioner of the Bureau of Health Equity and Capacity Building, Center for Health Equity and Community Wellness, and an internal medicine physician by training.
Hello again, and thank you. Yeah, I'll share a little bit about my personal journey through the chef fellowship, and also some of my professional journey, honestly, as a career physician transitioning into the public health space. I think a common theme that came up in our discussion in the last panel and our planning discussions, and honestly for the last 4 years, has been what do we do now? And I think that's a question I was asking myself from the very first day that that the lockdown came to New York City, from my Lower East Side apartment, looking out at the window and seeing how the city that never sleeps was brought to its knees, and how can we be sensitive to whatever the crisis that we may be responding to as physicians. And I think climate just really kind of became very clear over the last few years, and trying to see how I can use all of the skills that I have to actually address this thing and join a fight that I know it may be newer to me, but I know has been going on for a very long time. So yes, I'll talk a little bit about the work that I do, building capacity for community climate resilience at a local health department, using a health equity and environmental justice lens. So my issue is that and sorry, apologies for the size, but my issue is that climate change is a rapidly accelerating public health concern that disproportionately impacts marginalized communities. You see, I work in the Center for Health Equity and Community Wellness in the New York City Department of Health and Mental Hygiene. And a lot of the work that we do is focused on addressing the inequities in so-called marginalized communities, understanding that marginalization is an active process. It's not like the weather, it's not like the rain, that's just a natural thing. There's actually a lot of work that goes into it. A lot has been sacrificed to marginalize folks. And we often look at it from this lens of, oh, the poor marginalized people. We often forget to look at what's lost to our discipline, what's lost to us personally. And I think as a society, when we use mental models that are disproven, discredited, old and outdated, such as white supremacy and these other things. And so the problem is climate change is often seen as beyond the scope of traditional public health practice. Our discipline rather, we kind of use this siloing. There's experts who do their expert thing, and there's no room for crossover, no room for collaboration. You get your piece of the pie and you hold on to it, and you're the guy or gal. So my goals for the fellowship, but also my bigger goals for my work, is to build the capacity of the New York City Department of Health to respond to climate change, but specifically using a health equity informed and environmental justice lens. I think that when I look at health equity and how I was able to be my light, my guiding light in the work that I do, I chose to enter into the health equity work out of necessity. I felt kind of alienated in the medical space, seeing all of these different big problems, and all the tools that I had were telling me that you have to fix it individually. You have to convince these people that they have to do what I'm saying, knowing that no amount of personal action can do it. But I also knew something else. I know that communities have other ways of seeing and doing, and I know that that's where the strength is, in community. So that's why I felt it's important to use this health equity lens when we talk about climate change, because we talk about long-standing issues, complex issues that make you want to smack somebody. We do it, and we hold that difficult conversation, and we hold space for the humanity. I'm leading the restructure and transition of an existing community-based climate resilience program called the Be a Buddy program, out of the environmental health space and into the Center for Health Equity and Community Wellness. This program has been around. Some folks may be familiar with Be a Buddy. Been around since around 2016, and it was basically connecting folks to ACs and creating a list of folks that we call during heat emergencies. During COVID, we saw that these networks were important we knew that the heat vulnerable folks were also going to be vulnerable to COVID. So building that and really expanding that program in the Center for Health Equity and Community Wellness. And finally, the work that I do in the Bureau of Health Equity Capacity Building, we work on building the capacity of community-based organizations, healthcare providers, and community health workers And we're building on the model and all that we've learned during COVID and this massive vaccine effort, massive community engagement effort to really convince folks to kind of, well, not to convince folks, but to rather to build that trust or to build that confidence in the solutions that were developed. We think that it was important to apply all of those skills and all of those tools to climate change. And also, it's this internal work, building our capacity as an agency, capacity as practitioners, but also working with our partners together to build capacity in the community. Next slide, please. Oh, yes. Yes. Okay. So some of the key actions that I took over the last year, wearing my DOHMH hat, as we affectionately call the agency, redesigning the Be a Buddy Climate Resilience Program. We've expanded our work to start. We're gonna in June, we're gonna launch pilots in some of our older adult centers in partnership with NYC Aging, the New York City agency responsible for the health of older adults in New York City, to develop at the older adult centers a climate resilience model, kind of building on what they already have and to build up that infrastructure. Working with the folks to hopefully in the field of geriatrics, we'll think of climate just as the same way we think about falls prevention, just like we think about medicine reconciliation. I hope that's one of my goals. That's what I'd like to see. We're building agency capacity building, working from the ground up, working in my Center for Health Equity and Community Wellness to get that buy-in in our division, to understand that as health equity specialists, that we need this deep understanding, and that we should be the voices leading this. Speaking from the experience that we come from, speaking from the communities that we come from, not speaking for and being very sensitive to that, and understanding that we have to bring community in very early, and that we have to sometimes take unpopular opinions, and that's okay. Next part of the actions that we've been doing at the agency, integrating extreme weather response and community resilience into our agency preparedness work. A lot of the work that I have been doing since I transitioned from clinical care has been working around the COVID response in New York City. We were once an epicenter and have been epicenter many times. And for me, coming out of that work, I feel like it would be the best way to honor the over 30,000 folks who died because of COVID in our city, and to honor all of the folks who activated, community workers, all of the physicians, providers, everyone, the whole of society that really got together to respond to COVID. It felt really important to integrate all of that learning into how we respond to future emergencies. So with our pandemic planning, making it all hazards and bring in this climate focus. And then community engagement. We work with community-based orgs, faith-based orgs. We do a lot of training with community health workers. We're developing a climate health model training program, looking at many examples out there to train folks, and then working with healthcare providers. And honestly, relying on a lot of the tools that we've gotten from this fellowship, and really repurposing things or just directing folks to these resources. Strategic engagement. So we've done a lot of strategic engagement working with New York City Parks, thinking about how we can work with folks in the Parks Department and recognize parks as a naturally occurring healing space, and understanding how is an opportunity to talk about climate, to really address the climate anxiety, but also a way to really understand that there's a mental health crisis going on at the same time, and how we can kind of stack and have things feel more holistic and, again, not so siloed. I've done a lot of public speaking. I worked with the SEIU, which is, I think folks are familiar with, in New York City, when we had our air quality alert. For folks who are familiar or who are living in New York City or the Northeast in the summer of 2023, it felt almost like I felt very prophetic to have been talking about climate and to have people be like, oh my God, what, like to open the door and see Blade Runner outside your door. I also partnered with the Gay and Lesbian Medical Alliance to talk about climate to that group, understanding that these other marginalized identities, that there's a way to see and understand and be in community to respond, and then understanding the inequities that folks in the LGBTQ community do face in emergencies. And then finally, community partnerships. So I had the honor of last year to join the board of the Catskills Agrarian Alliance, which is a large alliance in northern New York of farms. They come together, and in the pandemic, they came together to work on mutual aid locally in the upstate region in the Catskills, but also in New York City. So working with local schools, working with mutual aid groups in the city to distribute resources of regional fruits and vegetables. Next slide. So my next steps is creating this climate health equity policy platform for my bureau, and also help to build it out for the rest of our division and agency-wide. We're going to launch the Be a Buddy initiative, as I said, working on this white paper to really discuss and unpack health equity and climate and our theory that we apply to this work. I'm going to remain an active member of the Climate Consortium. Came here today, hope to come back again. And then finally, can just continue my community organizing and advocacy efforts. As a clinician, as a physician who is not currently seeing patients in this chapter, I feel like that community-based work, meeting folks, going out in the community, talking to folks, that is the deep work. That is the right relation that communities are looking for. And I think that's something that we'll never forget. To how can I, as a physician, with all the skills and training that we do have, how can we join the struggle, join this bigger movement that is happening, and not see ourselves as the saviors, but actually see ourselves as, part of the Calvary that has been moving the arc of justice in this country for many, many years. So if you want to contact me, here's my contact information. And thank you so much for listening to us today.
Thank you, Dr. Watkins, such impactful work. Our next speaker is Dr. Cheryl Holder. She is no stranger to us here. She is part of the executive committee of the Medical Society Consortium and the co-founder of the Florida Conditions for Climate.
Well, good evening. Thanks for staying. And I know everyone's like, Dr. Holder is a fellow. Can you hear me? Yeah, Dr. Holder is a fellow. And yep, it doesn't matter how many years you've been doing this, how old you are, you can be a fellow. And when I got the opportunity mid-cycle, I jumped at it because you see who I got to work with and even more. And it took you through areas that when you're busy doing the work, you may not keep up to date on, and learn about regenerative farming, just so many aspects of the climate change world that you need and which can help to inform what you do. So I was really excited to be part of it, and I got to thank Bernice and Shanita and Mark and everyone for this. And if you get an opportunity to join these fellowships, please do, because you work with the different generations and it expands your knowledge. I always get this. Is this what I do to go forward? Okay. So my work that I chose to do for this is about heat, because I've been in the climate change, and in Miami, heat was the big issue, has always been, it will be for everybody at some point, some manifestation of the heat as it impacts the planet. But I will talk a little bit about the final project because you had to narrow it down to one area. But what I narrowed it down to is basically what I do, which is clinician education. How do we get clinicians out? How do we educate clinicians? How do we get clinicians to integrate this work into every aspect of your assessment and plan with the patient? And how do we get clinicians to expand their understanding of health to include the social determinants like you heard about, to understand that it's not enough to give the prescription, as you guys know, I'm speaking to the choir. So how do I do that? Now, we use collaborative, and I'm in a city that for many years, because of heat, because we're at ground zero, we've been involved in this work in some capacity. Not so much because of our political environment. Nobody ever talks about fossil fuel and reducing fossil fuel. But they do talk about some way to adapt and to become resilient. And looking at that aspect, we have always worked in collaboration. I always start off everything I do with this one patient who in 2016, that's not her, but she brought together everything that we know about medicine, and we know about the challenges of low wealth people who will present with a chief complaint that seems pretty simple. I need a medical refill, but it was just the tip of the iceberg. And when you unearth that and you see what happens, it just tells you what's happening in society. And that's what she did when she couldn't pay her light bill. And we all knew about the days and the nights, and she told me about it, and I heard about it, and then I saw all the changes, and we know all of this, but it happened, and then I learned all of this other information. So then what do we do about it? And that's where my project comes in. Now, my project and the issues that I saw was for medical students. And I always do this with medical students. How do I get medical students a little bit more knowledgeable in what's happening? And my role with this is the urgency. And many times in climate change, nobody addresses the urgency of this response. We hear solutions like carbon capture, that could be 20 years down. How do I get to urgency? Because that's what my community says. My community wants urgent action that makes them healthy now. And so when I do my education, how do I get urgent action that helps now? And then when I think of medical students, we have to have a good roadmap for them to understand fully. And the Global Consortium, if you haven't been on the website, because I don't have a slide that talks about it, the Global Consortium puts out 5 competencies: knowledge and analytical skills, collaboration, communication, policy, public health practice, and clinical practice. And they're great definitions of these competencies. And in medical education, that's what we want people to be really competent. Can you really describe what is climate change? What's the underlying human causes? What are the health impacts? Can you communicate about it? Can you develop the collaborative skills to be able to achieve these goals as a clinician? And what are the practices, when we say public health practices, that is not just that patient in front of you, is how does that patient and what you do for that patient and the community impact public health? And then clinical practice, how do you put that in effect with that patient? And just like that OB patient, that question you ask, how much cooling, do you have access to cooling during your 2nd or 3rd trimester? Do we even ask that question? Yeah, we definitely do the syphilis test, which is absolutely important, because especially now that we're in a pandemic on syphilis. But how do we then address another thing that is worsening the health outcomes? So how do we do all of those things with the medical student? And so my challenge was taking these 5 competencies, how can I get these 5 competencies right now in my community, bring that skill together? So what we've been working on in Florida Clinicians of Climate Action, I've been doing this for a few years with the team of the community members and nurses, doctors, everybody who's worked with us. We've said, how can we develop a system to train somebody pretty rapidly? And again, these are the issues here with the time. How do we get these urgent situations be incorporated in what the doctors do? And the key points about the weather-related killers, what's going to happen, how we can prevent this. These are the issues that the community wants answers to. And if we're going to have an urgent response, how can we answer these questions? Collaboration, we have an incredibly great organization because Miami, through funding and resiliency, developed a group to create a chief heat officer. And that chief heat officer helped to create the Climate Health Task Force. Under the Climate Health Task Force, which I am, the co-chair of the Climate Heat Health Task Force, we were able to get dollars for Florida Clinicians for Climate Action to really do that education. And with that, we developed the programs that I will show you what we've done. And with the Heat Action Plan, which was developed through the collaboration and the county. And when I'm showing all of this, really the take-home point here is that these things, very difficult to do one physician, even one health system, that if you're going to do any action that's going to impact urgently in the community, you've got to collaborate. You've got to mobilize those forces. If it takes you a year to develop that collaboration before you do a real action, you'll be able to sustain it more. The first dollars for the Resiliency 305 came down in about 2016. We didn't get funded. Catalyst Miami got funded in 2019, 2020. We got funded in 2020 to 2021. The chief peace officer was 2021. You see how many years before we can make these changes, but you have to do the work. And we are goal 1, inform, prepare, and protect the people. because of the work along the collaborative, the universities were able to map these heat areas. FCCA were able to use this mapping to see where the areas that are highest, what's the economic condition, what's the heat vulnerability index, which then the county worked together, and we identified, and based on the county, these areas were identified. Now, as clinicians, what we developed was we went to these areas and identified all the health systems and the health centers and the larger health centers within these 6 communities that were highest. You heard from Carlos Mejia, Homestead, which is here, which is incredibly hot, poor farming. That's one of the big areas. So one of our urgent response is that the areas that we went in to get the education by the clinicians first were these high vulnerability index areas. We then used lots of tools. NOAA, which is one of our partners, they have a great heat index app, and all your phones have weather apps. So as we educate, we have to bring things that can be used immediately for the population to be able to say, I want something done now. And that's what we did. We also worked together to make sure that health is integrated. And that's where the Heat Health Task Force and the leadership with FCCA, that we make sure that when these advertising goes across the county, and this is one for pregnant ladies. We did one other campaigns throughout. There's a launch of the mapping, so anyone can learn how to do GIS mapping. We developed our entire strategy around we did climate education with CMEs, all these different steps. That's our foundation in our program. We also developed a heat toolkit. And this toolkit became part of the overall program we call the Climate Health Outreach Team. And each Climate Health Outreach Team can address a particular area. And we have our team right now addressing heat. It could change to whatever area we wanted to change to, but right now it's heat. And we create the brochures. Where's that brochure? You see this one here? That's one everybody uses that you saw earlier. It's really good. We also developed this extra Survive in Extreme Heat. We developed that one from FCCA, and that one that's developed does a little bit more for the clinicians. So we created this toolkit. We did CME courses as part of the project to educate. And in the end, we did 12 webinars, all of this that was here. We also developed an IRB project. All these surveys that we give out, we wanted the community to tell us what they thought about it. So when we go out there and we say, here's all this stuff we're teaching you, they get $10 if they come back and finish a survey and tell us what they think about it. And we also, I use this a lot because I get it from COVID, which tells us multifactorial, multiple solutions. And before I go back, so all of these factors come together. So now how does this work with my medical student practicum? That's the foundation. So we developed that 4-hour training program for any community member to do it. We then tailored that 4-hour program for medical students. So when we went to the medical school, we say, we have a 4-hour training program that at the end of these 4 hours, these students will be able to come with us in the community, go in with the docs, go in any volunteer. You saw those health centers we go into, the medical students are with us. Knowledge and analytical skills, competency 1. They're self-directed learning because our program is virtual. And then they have to do a mock video showing how they would do this talking and education. So they learn how to do their knowledge analytical skills. Communication. We use the Ask, Tell, Ask, which goes along with the curriculum that they have. And we supervise them. So when they go out with doctors and nurses, and their communication skills are observed. So competency 2, we improve their knowledge skills and competency 1. Competency 2 is collaboration and communication. We collaborate with nurses, other clinicians, students. So when they go out with us in the community to do this teaching, every medical student is working with other people in the team. And we go into health centers, we go into free clinics. When Carla saw us in Homestead, there was also a free clinic giving healthcare that the students could also participate in delivering healthcare, but then their role was to do climate and health education that we taught them. The public health practices, the advocacy, we have the whole heat effort turned into another effort to get some ordinance passed to protect the workers. One of our medical students wrote an article and an op-ed with me, so that developed their public health and their advocacy skills, which is another competency. And another one wrote an article for Invading Seas, which is online. Another student, a high school student, wrote an article about heat and the outdoor worker for her local newspaper. That was the high school student. So there are opportunities to advocate. They become part of our advocacy action plans. They have to call, there's a PSR. If you go on the PSR, you'll see a student who did his social media thing about heat and about the program. They participate in our social media activities. We bring them in. Another thing is in fundraising. We did a huge Give Miami Day to raise funds for FCCA. Our medical students did the videos. They got the fundraising. So another one of the competency covered. Clinical practice. Ask Till Ask is one of the earliest things that we teach them in how to communicate with patients and how to teach patients. Tell me what you know about blood pressure. We use the same format, so they also learn about all the health factors, and they're learning how to use it in their clinical practice. So we hit 5 competencies in this practicum. They get 30 hours and they qualify. That allows them for their graduation requirement. So that's what we have been able to do. And we have them meet patients, like this was my patient, Jorge. So when they're out, they meet the community. And that's probably one of the biggest things that we try to do in our practicum, is that they meet the community and they understand why they work. And when we talk about all these health issues, they can put a face to it, because they were in that waiting room and they met the patient. They go regularly to the free clinic, they go regularly to different areas, and they hear the stories from these patients. And we hope that is what's going to make these medical students continue this work when they graduate. So our next steps is to evaluate first the surveys, and then I want to see what's the outcome with these medical students with this practicum. We have done 2 orientations. First orientation had about 30-something medical students show up. 10% of them, we had 20% from the first roll completed the process, because you don't qualify to come out with us and write essays. Oh, curious, we would have our first publication, we're crossing our fingers, on anesthesia and vector-borne diseases. 2 of our medical student practicum with a anesthesiologist have looked at vector-borne diseases in anesthesia and the impact in anesthesia, and hopefully that will be published. So they also get the opportunity to participate in the research. So at the end, our evaluation, see how many papers, of course, all the metrics, how many papers, how many op-eds, that kind of stuff. But a real thing we want to do is the outcome. What is the impact on the medical students' understanding of climate change and the impact of them working in the community, having that story to tell, and keeping that hope? And si se puede. Thank you.
Questions, and while folks may be thinking of their questions, I wanted to ask each of you to talk about your voice. There's been a thread throughout the entire weekend about your voice and how important your voice is, and that your voice is not just your personal voice, but or your self voice, but you represent the voice of many different communities, your profession, and so on. How do you ensure that you are accurately representing the voice of the communities that you are trying to help?
When I think about the voice, I think about it in this legacy of Black liberation, and just understanding the power of the voice and how without the guns, we've been able to change this world. How our cultural practice and this meaning and value, and these values that, you know, inform the work and these legacies, what we've been able to accomplish. And so for me, it's really tapping into that and finding how my voice fits within the broader context, how I can build on that, how I can grow on that, how I can refine it, how I can get the language to get better, how I can understand, how can I get that intellectual engagement, but also get that emotional engagement and try to touch something deeper and really inspire folks to imagine or just believe that it can be different and that the world as it currently is ordered is not the natural way, and that we could actually change this thing. And we've been surprised before.
Thank you.
It's an amazing answer. Yeah. Yeah. Well, I mean, it's so human, right? You're holding a lot of realities at once, right? And sometimes that's hard for a lot of people. It's easier to do one or the other. Like, here's the hellish, hopeless reality, and here's your reality where there is hope. But that means that you have to be able to see things and know, gosh, this is horrible, but there's a place to go from there and everything. For me, and I'm looking at your patient, Jorge. I see pediatric patients, but like, I see families, honestly. And as a Latina, I get a lot of Spanish speaking patients. It happens. Like, I was out, not in my current position, but at a different position, where somebody bull-faced is like, okay, you're gonna see all the Spanish speaking patients, which is good and fine. But like, and I have to say, as a pulmonologist, I see a lot of chronic disease as well. So I'm actually seeing some of my patients more frequently than their pediatrician, their general pediatrician is. And so I learn a lot about the families, and it's surprising because it's over such a long period of time. Because one encounter, even the prolonged encounters that sometimes we have, it's not going to tell you what's going on with somebody. Going out and seeing Jorge is, but asking a lot of follow-up questions of people and seeing where they're at. I was surprised at one point with one of my patients when we were talking about adhering to CPAP for obstructive sleep apnea, which, if anybody has obstructive sleep apnea and they use their CPAP, oh my God, it is life-changing. So this is like, it is life-changing. But she told me, we don't have air conditioning. She lives in San Jose, which gets really hot in the summer. So, if it's like 100-degree day, no air conditioning, she's not going to put something on her face with heat and humidity, even though it is going to help her feel better. It feeds into other health issues and everything like that. So just honestly talking to people, getting to know them. I have to say, my families that do use Zoom, because not a lot of my Latino families, especially at the beginning of the pandemic, were embracing Zoom. They were actually a lot of my patients that would come in person, because I think we stopped for like 2 weeks, and then we saw people in person. But the ones that I could see through Zoom, you see houses, you see the environments that people are in, and it's just really those one-on-one connections. And I think Julie and I were talking about this, is, in academia, sometimes if you're a clinician educator, you're seeing a lot of patients, it's sort of like, oh yeah, but what else do you do? Which is like, well, this is why I do this. I see patients, I'm connecting with people, I'm trying to treat people, right? And so it's that one-on-one, trying to get to know where somebody's coming from. And then I can actually use that voice, both, intellectually and emotionally. So, but some of it is I have to shut up first, and listen.
For me, it was much easier because I used to do household visits for about 10 years, and we'd go into many homes in my whole Miami-Dade community. So it's not unusual to go into a home like Jorge's. And I mean, that is his window, and it's small and it's hot. So, and you would get to know them. So it was a lot easier to know that we're doing what the patients are, what the community is saying, because we were out there. I say what we've done is develop a structure, the collaborative structure. So when we develop our team to go into the community and educate, the team has nurses, students, and we try and get folks from the community to participate. We get Black nurses, we get people from the church, we get doctors, medical students, and they generally come from the community. So it's designed to have the students in it and have the community be part of the solution. So it's a lot easier. And then when you do a lot of one-on-one teaching, you hear the stories. I was in Homestead and the lady was talking about, I went to sign up for that free program, not the free program, the program to get the energy assistance, and they're all out. And it turned out she was right. But when the refunding, but then there was a refunding where they increased the dollars again. I didn't have her information to get back in touch with her, but I could call up the county when I got back and I said, what happened? The money ran out. They said, yeah, it did run out. So we can hear what's happening. And now I realize the money ran out so much earlier because it was so hot last summer. So the money ran out way earlier than it usually runs out. And so that's now a huge issue that I have to look at, policy issue, because the refunding was much too late and too many people. So when you're out doing this in the community, in the high vulnerability area, we're talking to the patients, we're getting the feedback, and they're also talking to people who look like them many times or have the understanding of how to communicate with the group, so they tell them their stories, and so we bring that back. And then because the task force has other collaboration around the health, we have meetings, so that information then gets sent up to other areas. So I think it's structural. Again, if you don't build it structurally, the voices you'll hear, but where do you take them? And so I think structurally having the Heat Health Task Force, which is linked to the Heat Officer, has a system that we can carry the information back. Because I got the information directly to the Heat Officer that money ran out. By July, the money ran out. And so they're looking at these issues. So you got to get it from the community. You got to be out there. Not everybody can. So now the researchers look for our group. So we're now trying to get funded by another organization, by the county, for us to take this into Broward County, the climate health outreach team, and develop that concept in Broward County and have them be the voices and the educators and bringing the information back. And Broward County has heat, but they also have flooding. So we're going to look at bringing in the flooding education in the vulnerable areas. So, it's not perfect, but it sort of gets more real-time, urgent response, again, which is what the community has asked us to do.
You have all undertaken significant initiatives. How are you ensuring progress in the face of sometimes naysayers, obstacles, red tape, etc.?
In the New York City Public Health Department.
Yeah. I mean, honestly, it's when I realized that I had reached the limits of what my medical training provided me from this individualistic, patient to patient to patient approach, I had to look somewhere and actually look to social justice movements and into studying movement. We're engaged in a movement. Many of us don't realize it, but we're engaged in a climate movement that's been here for many years before us, is hopefully going to be here many years after us. So really tapping into that really, and understanding that you have to build a coalition. You have to meet with many different stakeholders, understanding the importance of partnership, of solidarity, and ensuring that someone understands what you're trying to get at, so that I'm not the only one, speaking into the void. I want a range, a coalition of people, different experiences, folks who are into the environmental health space and the scientists, folks who are clinicians, folks who are community health workers, folks who are, so if it's building a coalition and having other folks recognize and see their place in the bigger environment, that I think has been helpful for us to kind of keep this going, and finding a way to look at the challenges as not the end. It just as an opportunity for us to try something different, to be creative, to use our imagination. And again, I say it, but like, we've been surprised before on so many things. And when you get surprised again and again, it makes it all worth it. And it feels like, that you can fight this dragon. Yeah.
I've been really clearly communicating what we do with FCCA. So so you avoid mission drift, avoid folks' expectations to be beyond what we do, so that we can be guaranteed to sustain our work. And so when I tell folks, when I see FCCA, when you come into Florida and you want work around clinician education, climate and health, and addressing the health issues, that's FCCA. If you're looking for somebody to come and do service and go do some PTA meetings and this meeting and that meeting, that's FCCA can help connect you to that person and connect you to that organization. But that expectation, that's what we do as clinicians, no. And so that's what we've been trying to really clearly articulate what our role is and keep it as focused as ever and avoid mission drift. So when they come to fund us and we go for funding, everybody understands you're getting a professional organization that is going to ask the questions, educate you appropriately on what is the medical evidence, include some research to prove the effectiveness of whatever our action is, and that's what you're funding. You're not funding a nice come and let's talk to the PTA group. I will get you the Miami Climate Alliance. I'll get you the Moms Clean Energy. I'll get you to the volunteer student organization interest group that does that. And they do a great job because we'll train them how to do it. But bring us dollars to train people, bring us dollars to do your research, bring us dollars to connect you to the absolute experts on climate and health. That's what we do. And I think that will be easier to then find the metrics that evaluates our success and the ability to communicate that clearly to the next person that we want to join us. And so that's what we've been trying.
I'm curious what and I'll answer the question, but I would just piggybacking off of what your comments are and knowing where you're at in Florida with
Yeah.
the political climate in Florida, how has that presented a challenge to really sustaining your efforts?
The thing is with politics, they can say whatever they want to
Mm.
say, but they're feeling the heat. So
So to speak.
I'm like, so they're willing to come in the mitigation effort. And I tell everyone, we are nonpartisan. We will speak truth to the Republicans as much as to the Democrats. The heat is real. The impact is going to get you sooner or later. And my patients are the canary in the coal mine. So you give them thanks for screaming that you're going to suffer like us. And they're here to help you. So let's join in. And they'll give me some dollars for mitigation. Not mitigation, for adaptation. They won't do for mitigation. So mitigation, I will go outside of Florida. But I have to do the talk about human. I said, I'm a doctor, I'm not gonna lie to you. And that's why you trust me.
Dr. Morales, you have our last comment.
Oh, okay. So it's interesting because I feel like I'm a little bit of not a little bit of like a newbie in some of these spaces and everything, and really trying to figure out, how to navigate a lot of working with a group at a national level that's a professional organization, but has a lot of challenges. And so I have been really persistent and going like, okay, we talked about this 3 weeks ago. What do well, can we have a follow-up meeting on this? Can we come back to this? Like, how do I get this done? And I would rather go through this national organization because there are so many members, even though they're having issues with their membership base and it can grow. It's the biggest base that we have of Latino physicians. And what we want to do is try to amplify voices. And I know that there are a lot of things that members can be engaged with, and climate change and health is one of them, but it's a big thing. And I think it's a big area that we can grow. It's just that with some of the other challenges in the organization, it truthfully has been hard, but it's just that persistence of coming back to it. Hey, we talked about this 2 weeks ago. Hey, we talked about this. Oh, hey, can you talk about the application that I submitted? What's the status of it? Okay, you want for me to do this? We'll do that. Okay, so what's the next thing? And building those relationships and building that trust, which I know is going to take time and patience. You know, again, it's not something that I necessarily want to keep on doing alone for a long period of time. That's the whole goal though, right? Because alone, I can't really do anything. I can't do anything alone. It's trying to get the collective. And I think that that's the big thing. And that's the big thing with Chef is that it's not one voice, it's voices. Yeah.
Yeah, I just would say that all of you have spoken so eloquently about the power of community organizing, and that to me is the underlying theme of using not only your authentic voice, but using it in a way that amplifies the skills that you bring to the table, but also the recognition and the connections that you currently have, understanding that you can always build on those connections. And so the reason that Chef is so valuable is because it does build those connections regionally. And it's great that you're from New York, you're California, you're Florida.
Yeah.
So there's such great representation in terms of the location, but also the specialty and the discipline. And so the value of hearing from a pediatric pulmonologist who's sitting next to an internal medicine, who's talking with an OBGYN, the collection. And it's so interesting. We, as physicians, are trained to think holistically, and yet we go and do our subspecialties.
Yeah.
And we lose that perspective. And so this is really sort of a reconnection of thinking holistically about solving this huge problem. So I'm, again, extremely proud of the work that you've all done. And the fact that we are part of this connection that is organizing in different ways to make sure that there are multiple ways for us to attack the problem, but also to see the victories and to share those, because there are victories to be had. Yeah. So thank you.
We have one question. Yes.
An observation.
Yes.
Your beautiful stories. I don't remember who said these words, but these words came to mind. No one can do everything, but everyone can do something. And you are all doing something incredibly important, and that is true of everybody in this room. And you know, I don't like to get carried away with my own Pollyanna vision of the world, but boy, when I hear your stories, it gives me great hope. So thank you for that.
Thank you.
Phil?
So this is probably a question more for Julian, but you mentioned working with, disadvantaged, vulnerable communities in New York City. I have a brother-in-law lives, we'd call Upper West Side kind of more broadly. He's run the business improvement district there for probably 20 years or so. And his neighborhood, South of Columbia, there's everybody from billionaires to, day laborers and unhoused people, in between. So I think about, his neighborhood even, and like who's vulnerable, differs from like building to building, apartment to apartment. So I'm just wondering, like, how do you kind of approach that in New York City? It adds a lot of complexity, obviously. When you think about, usually a disadvantaged community, you think of a zip code, so.
Yeah, I mean, I think it's like fundamentally, what are these communities? I would say that in your brother's community, there are these disadvantaged people, but like, do we see ourselves as in community with them? Do we see what's happening to the unhoused person or the folks living in public housing as our responsibility? And I think for us is to really, what we're being called to in this moment is to start thinking that way. Because everything that we're told about shoveling all of the dirt and all of the shame and all of the exposures on all of these frontline communities, it actually does not make us any safe. The folks coming from a different type of class any safer. It doesn't. It may delay some of the inevitable, but it's all killing us. And until we can actually see beyond our, the building that we're in and see, how do I want my community to be? Is it advantageous for us to have unfed, unhoused children who see massive wealth? Does it make sense to have 100,000 children in the New York City public school system who are dependent on their primary meal for the day, eating at school lunches? It would seem advantageous that we have well-fed neighbors, well-kept neighbors. And so how do we look at the purpose of all of this and understand that we all can't accumulate the way that we have. We can't continue seeing ourselves as isolated communities by the little box, the black, the white, the this, the that. It's really how we change. It takes the change. to understand that we're not gonna all get there on our own, and there is no bunker that goes deep enough. You know what I'm saying? There is no bunker that goes deep enough, or no way that we can really prepare for what it means to live in a world of collapse. But it's on us to really know that there's a call that we have to answer. And I think it's us calling and rising to that moment and seeing things different, and know that what's required of us is it's a challenge that's ahead of us, but we can do it. We've done hard things before and we have been surprised. We just have to keep the faith, sometimes shuffle the cards if we must, but we got to look and think about things a little bit different, because the current way ain't it, and we're not going to get any better with the silos, with the, with the division and all of that.
Yes, we
Thank you
can.
so much, Dr. Holder, Dr. Morales, Dr. Watkins, Dr. Curry. These are 3 of the 12 fellows who graduated in December and joined our alumni network, which is now 30 fellows. And we have some of our 2024 cohort in the room. They may wave their hands. Please do. Please do interact with them, welcome them into the fold. And thank you again. We'll see you again for the next annual meeting.